tingin ka na pwede. So, good afternoon. Hi.
Hello.
Doc.
Okay. Okay. Can we start? You have classes at 5 o'clock?
Yes, Doc.
Yes, Doc.
Okay.
Yes, Doc.
Anyway, if we lack our on time, we will just extend up to 5 o'clock. In case lang, no? So, good afternoon. So, we will be taking up this afternoon the psychological testing and some laboratory tests that we are using in psychiatry. No? But however, unlike in other diseases that usually laboratory is the confirmatory test. But however, in psychiatry, it's like, for example, your shrinking of your, the sulcus of your brain becomes not so profound. It's not that major, what you call that, characteristic of certain diseases, of psychiatric diseases. It can also be a disease of other organic disease in the brain. No? So that's why it is said here that your psychiatric diagnostic, your laboratory is only plays a minor role in psychiatric diagnosing. No? Because there are other findings that are common also to other diseases. So, what are the importance of your psychological evaluation? No? So, you have intelligence test. So, this is used especially in mental retardation. And nowadays, usually, it is used during court cases wherein there are abuses to the child or any other women or children. So intelligence test is very important. No? So that is a psychological testing also. So you have also other neuropsychological testing that is very important for organic brain disorder. Like, for example, those who have strokes, those who have malaria, and other, like cancer in the brain. So it can also be detected in psychological testing, but it cannot diagnose. But it can only be shown that there is an organized brain damage. So usually, these examinations are standardized, meaning to say it has been already used and have been proven all over the world. So these are the importance of your psychological testing as well as your laboratory testing, although it's not confirmed or does not confirm in diagnosing psychiatric illness. So you have types of tests. You have objective tests, and there you have projective tests. So in your objective test, you use here some, what you call that, like in mathematics solution or statistical analysis. Then, like the Minnesota Multiphasic Personality Inventory, it is an objective test. However, your projective tests, this usually would tell your personality, your emotional factor, your psychological aspect during the time of the examination. So that's why projective test has no right or wrong answers, because it would only tell your emotional as well as your beliefs, no, your other factors that could affect your emotion. No? So another is your intelligence test. No? As we said, it is usually very important when the child is mentally retarded, but in any other test, but intelligence test is also important when you are also applying to work, because nowadays some offices would request the applicants for an intelligence testing, and sometimes in your intelligence testing it would reflect whether you can be recommended for that particular work, because you can see that your intelligence quotient, it is mental age over chronological age times 100. So that is your intelligence result. It is the ability to assimilate factual knowledge. So when you have your intelligence testing, the psychologist or the psychiatrist can recommend whether you are fit to work or not fit to work. So when you are having this psychological testing, it does not only entail one testing. So it's very expensive because we order that testing in Manila. No? I don't know why it's very, very expensive. No? Intelligence testing, personality testing, so many tests, no? And it cannot be Xerox or repeated one in one paper. So when you use that one paper, you do not have to Xerox that, no? Even a blank examination. No? You have to, for how many, if you have 20 targeted, 20 applicants or 20 patients for any psychological testing, you have to order that number. And it costs, sometimes we order 500,000 worth, no, for the examination. So the testing is, the price is according to the test that it is administered to the client or to the patient. Intelligence testing, that is another. I don't know the price here because only the psychologists, they have costing, no? Personality. No? So there are many kinds of tests. So it depends. So you have this Whistler Adult Intelligence Scale, no? Best standardized and most widely used intelligence test. This is for the adult intelligence test. No? So it has been established in New York, no, and at the Bellevue Psychiatric Hospital. It has been started in 1939. No? So it has had many revisions already. But it is important that you know that the intelligence test that is most important for an adult is this test, the Whistler Adult Intelligence Scale. So one day you will take psychological testing. Maybe some of you had already taken psychological testing. So you have the subtest and the Whistler, no? Verbal subtest, performance subtest, verbal IQ, performance, combined or full scale. Intellectual abilities are normally distributed throughout the population. So it has been studied already. So you have the so-called bell-shaped curve. So you have adult personality assessment objective. So Minnesota also, no, for personality test, no, your personality, your emotional, no? test your psychological, no? What are your fears? That is your adult personality assessment objective. It can be shown here. Your fears, your anxiety, no? It would reflect here. No? So it is most widely used, most thoroughly researched objective personality assessment instrument. So you can see that psychiatry is also a science, no? Because it has been, before it can be applied to anyone, it has been already tested before. That is adult personality assessment objective. Then you have structured clinical diagnostic assessment. No? This would reveal the severity of illness. No? And if you are to recover. However, it is limited mostly to depression, to anxiety, no? To obsessive compulsive diseases, no? And other dissociative disorders. So this structured clinical diagnostic assessment has its limitation. So you take note. You can see here projective personality assessment. So though it is standardized, but there are times that the test is an ambiguous test stimulus or stimuli. You know? So as I've said here, your needs, your characteristic, your defenses, your fears are even projected in your projective personality assessment. That's why here, as it is said in the previous example, that there is no right or wrong, because that would entail only your characteristics as well as your needs and your defenses. So it can be shown here in your projective personality assessment. So one is your Rorschach test. That is one example of projective personality test. So the psychologist is the one who is usually are doing this testing. No? So usually here we do not use this Rorschach test because it's very, it's timely, and it takes time, no? Having this test. So there are other other tests that can be used as projective tests, no? Because it would entail time. Then you have thematic apperception test, no? So usually our test is usually taken from other hospitals that have been proven already, like your thematic apperception test. This has been established in Harvard Psychological Clinic. No? It has pictures, 30 pictures, and one blank card. But not all pictures are being used. So it is randomly shown to the client. No? Choice depends on what conflict area the examiner wishes to clarify with a patient. So you are being shown with these 30 pictures, but it would depend on how the examiner would request, because you are to clarify on the picture if you have conflict of that particular picture. So it requires the patient construct or create a story. So you have to make story out of the picture that you chose. Then you have sentence completion test. So patients are asked to complete in their own words, write down the first thing that comes to mind. Maybe some of you have taken the sentence completion test wherein this is standard test questionnaires wherein there's already what you call that, a phrase or a started sentence, then you have to continue that sentence. And the first thing that comes into, usually this is 60 question tests, no? And that the thing that first comes into your mind is you have to continue. For example, my father seldom. So what will you continue? What is written only in the sentence completion test. For example, number 1, my father seldom. That is the word or the phrase that is being written there, and you are to complete that sentence. So you can see that what are the importance of the sentence completion test? Responses that are expressive of strong effects. Example, I am afraid. There's also there a phrase wherein, or a started sentence which says, I am afraid of a snake. So that is expressive of strong effects. No? So another, because in that sentence completion test, sometimes the started sentences are repeatedly asked since it is 1 to 60. So if you answered in 1 or 2 repeated answers, so there must be something about your answer. For example, I am afraid of a man. In another sentence or another number, I'm afraid of male. No? So you have to follow that up when you see the patient. You have to talk to the patient. Why? Because it comes out in the sentence completion test repetitively. So there is a meaning to that. No? Then another is unusual. So sometimes the answers of the patients or the clients is unusual. Like for example, when I see a man and a woman, they are always on sexual activity. So in a normal way, you cannot, normal patient or client, you will say, when I see a man and a woman, they are husband and wife, or they are friends. No? So these are the importance of your sentence completion test. No? Another is informative. No? There are things there also, I cannot just memorize the up to 60 started questions that is unfinished. No? That would tell, for example, I am happy that my father is around, although her or his father is already dead. No? So there must be something that you want to show why you are happy even if your father is already dead. So maybe your father provides you everything, he was good to you, you are missing him, you are having some sadness that he is not around anymore. So usually the patient here or the clients, we encourage that what comes under mind the first thing that comes to their mind should be the one to be written. Why? Because this is 1 to 60, and sometimes the client or the patient would discourage because it's very, very long. No? It's 1 to 60. There are two choices whether you will answer that. There are questions that are in English, or there are questions that are in Filipino. So if you answer in English, all of the 60 questions should be answered in English. Not that you have to answer both English and Tagalog. If you are comfortable in English, so you have to answer in English. If you are comfortable in Tagalog, you answer in Tagalog. So these are the importance of that sentence completion test. Then you have your word association test. So sometimes it depends on the word that is the word association test. So there's stimulus, the word. No? So the first word that would come into your mind, you have to say something about it. That is stimulus, a word. So what comes into your mind in that particular word? That is word association test. Another is draw a person test. Here, the client or the patient is being, or you're told to draw a person test. So before, it is used as a measure of intelligence in children, but now we have already intelligence test. So this one, draw a person test, this is just a projection of yourself. No? So we usually require the patient or the person to draw. For example, we'll tell you, draw a person, but it would reflect you as a person. You may use the third party, but still it would come out. Some of the questions that we are asking would come out as an answer of yourself. So it is a projective test. Draw a person test will tell who you are, even though you will use a third party or any other person. But as we go along, as we ask questions from you, it would come out who you are, what are your fears, who are you. So that is draw a person test. Sometimes we would ask also, draw a house, tree, person. And this tree, house, tree, person, is also showing the kind of person that you are. So we, until now, we're still using this one. But mostly, to cut short, we only allow a person test. Although we can have a tree and a house. Draw a house, tree, person test. But for the cut short, as I've said, we only allow you to draw a person test. Then you have neuropsychological assessment of adults. So, what are the indications of this neuropsychological assessment of adults? So, it identifies cognitive defects. Why cognitive defects? As I've said, there are tests, like as I've said, the intelligence test. Of course, your intelligence, your judgment, your cognition, in other words, whether you have a defect. Like for example, as I've said, those have strokes, those are depressed, that would reflect in your neuropsychological assessment test. So it identifies cognitive defects. It differentiates depression from dementia. Sometimes we are misinterpreting when we have some, to call it dementia, when we are forgetful. But there is the so-called pseudo-dementia. When we say pseudo-dementia, it means that there are tests to that. It usually happen, or it would reflect when you have depression. That is what you call pseudo-dementia. Because when we tested for a dementia test, examination, the patient has no characteristic that he is or she has dementia. So it would show that he has a depression. That's why you have it differentiates depression from dementia. So we know that this patient is having a depression, because there are times that during court cases, some of the lawyers would say that, oh, my client is just having some, they're just making some lies that they are psychotic or they are depressed. But sometimes we just say when we examine the patient, they could not hide us because we have this neuropsychological examination. So we know whether the patient is just malingering or telling lies, because we give this psychological examination and it is being shown there whether you're just telling lies or there's truth in the result of the examination. So at the first, you can see cognitive, depression, the course of an illness, whether you have remission, or it is coming just, then gets out again, come back again, So that's the course of an illness. This is usually found in depression, because usually in psychosis is, there's remission, but in psychotic patient, usually you will know that the patient is really schizophrenia. From the very start to the end, you will know really. But in depression, sometimes when the patient comes to you for the first time, they are depressed, but there are times that they are on the normal emotional aspect, or sometimes they are also in the manic phase. So you can see that the course of an illness can be shown in your neuropsychological assessment. So you cannot just say that, oh, he's just making some lies, so sometimes, as I've said, when we go to court, the lawyers would tell us, oh, they're just making lies. When I talk to the patient can answer questions. So yes, they can answer questions. They even know the person. But in your mental status examination, our brain is divided into many different areas: judgment, impulse control, insight. So you will know already when you are trying to get the patient, whether the patient get the diagnosis, whether the patient is just lying or not. Because just by the neuropsychological examination, we know that patient is just having malingering or just lying. So I would not believe, and could not believe that sometimes, especially in court, that, oh, they're just telling lies, they're just having malingering. No. Because of this neuropsychological assessment, especially in adults. In children, it's very easy in children also. There are anyway some other examinations, Then other aspect of your assessment result is the assessment of the neurotoxic effects, memory impairment by substance use. So whether the patient is using substance use or having using shabu or alcohol, so it depends. So it would reflect also in your neuropsychological assessment when you take this examination. Of course, I will mention some important psychological tests, but deeper to that, when we assess the patient, we really know that this patient is having this kind of illness. You know? So they cannot tell lies to us, even if they said that, I know this person, because some patient, yeah, I am with other, when they said that, they know their names. I asked their birthdays. Of course, that's memory. Diba? During our examination, your mental statal examination, the first that would get lost is time, place, and time, then place, then person. So even if the patient is very psychotic, the patient still know who the person is, who the person he is with. So sometimes the family would say, oh, they still know me, nakilala pa akon. But actually the patient is already psychotic. Even a grossly psychotic patient, they can even identify or they are even oriented to person. But in other examination, they cannot anymore take the right answer. But yes, in orientation, they are oriented, but in other aspect, which the layman would claim that, oh, they still know me. They still know that she is my sister. That is only a part of the examination, especially the mental status examination. So that is an orientation. There are others, and you know that during the mental status examination. You have your insights. What else? You have your memory. You have your impulse control. There are so many things that to be considered when you take the neuropsychological examination. Not only who the person is, because mostly, as I've said again, even the grossly psychotic patient know whom they are with, their father, their mother, they know. Unless the patient is already have a chronic or chronicity of, for example, schizophrenia or mentally retarded. But when you go on your clinic, so do not be distorted also that the patient, the patient can still know me, they can still identify their parents. Yes, they can still identify, but that is only a part of the functions of the brain. There are other aspects of the brain, the temporal lobe, the frontal lobe, your somatosensory, where is that? The parietal lobe, There are many parts of your brain that have the function, not only orientation. So that's why you should not believe that when the layman comes to you, oh, doctora, they still know me. So I think she just need a hypnotic. Hypnotic is just to let the patient sleep. When the patient is psychotic, he cannot be treated with a hypnotic drug. You have to give an antipsychotic. So do not believe that. That's why they are subjected to neuropsychological examination or evaluation. So you can say also learning disorder. So it can also projected in your neuropsychological evaluation. So there are many things. There are many other aspects. It's only a part, This is only an example of the importance of neuropsychological evaluation or neuropsychological assessment, especially in adults. So you can see that the reasoning, concept formation, and problem solving, it's in the frontal, when it happened, you can see that there is a problem of frontal lobe disorder. So there is a problem in abstract reasoning. What is abstract reasoning and what is concrete reasoning? So you know, when you ask a patient, especially when psychosis or other psychiatric problem is an organic problem, there is usually a problem in abstract reasoning. What is abstract reasoning? For example, what is the difference between a ball pen and a pencil? I've been giving this to you. So usually the patient will just say, oh, the ball pen has an ink, or the pencil is a yellow color usually. But when you abstract, so you can say that the ball pen is very difficult to be erased, while the pencil is just as easy, as to erase when you write it, you use it. So what are the tests that is used when you have a reasoning problem? So you can see that Wisconsin card sorting test. So at least you know, when you go on testing one day, when you work already, you will be having some neuropsychological examination. So you will know when you will see this Wisconsin card sorting test, you have to just recall the test that I am telling you. It can assess abstract reasoning and flexibility problem solving. So when you there are scores, of course, there. So when you're at the high score, of course, you can see that you have a good reasoning, can be flexible, especially in abstract reasoning. Because in psychotic patient, the reasoning is very concrete. I have already given you what is the difference between abstract and concrete reasoning. Another is the colors and of the card and the form and the number. The stimulus. These are the stimulus. These are only the psychologists know this. The interpretation of the stimulus, of these different colors of the card, of the form, and the number. Usually here the patient has an organic brain problem. In this stimulus, when you use already the cards, the form, usually it's an organic problem. So it must take into account, but of course, before giving this, before giving your neuropsychological evaluation, or of course the psychologists or the psychiatrists know when to give other deeper psychological examination. Why? Because you have to take first the educational level. Of course, maybe the patient cannot read. So how can you give this test? Of course, the intellectual ability of the patient. So of course, you take first the general intelligence test, whether the patient is mentally retarded or not, because you cannot get into other examination if the patient is mentally retarded. Like for example, I have a patient, I told you, the mother told me that his son is already 4th year and he was about to take the examination for the college, an entrance examination. And he took time for him to study. He was not able to go to sleep, just to study. But only to find out when the patient was brought to me, when I asked the patient, of course, the more that the patient was not able to, or has behavioral changes when he arrived at the clinic, because he was not able to go to sleep, he cannot answer, and only to find out that the patient is a mentally retarded patient, which the parents does not know. Sometimes they consider that as normal. For example, the patient sometimes have some characteristic or behavior which is acceptable in the culture or in the society. And sometimes you will say that, ay, asyala itong hiya, no? Before he is very silent, and now he is already very accommodating, no? Very sociable, but only to find out that the patient is already having some bipolar 1 disorder. So that you have to take this consideration before you get into the deeper neuropsychological evaluation. Enough, like for example, draw a person test. You will already know just by having this drawing whether the patient is mentally retarded or not. So, do you have to give any other deeper psychological examination? No more. You're just wasting your time because it can already be shown, it can already be detected even in the house 3-person test. So these are the consideration, of course, before you get into the deeper psychological evaluation or the specific. You have to take those educational level, the intellectual ability, the culture, and the subcultural membership. Diba sometimes in our place, ay amo lang itong tiyak kinaiya. But you do not know that the patient is having, again, some manic characteristic. Ay amo lang itong hiya, kuan. No? But you do not know that the person is having a problem, a psychological problem, or a psychiatric problem. So it's very important also, I've been telling you, no, it's very important also that you know the premorbid personality of the person. As I've been telling you, some of us would tell, ay, amo na tiya, di rin lang mayakan. Pero yan, mayakan naman ni tiya. Nag-iba naman ito niya, very sociable already. Only to find out that the patient is having a bipolar 1 disorder already. So you do not have, you have to have a very good observation, and you have to bring that to a psychiatrist when the patient has already changed his premorbid personality. Because when the person has premorbid personality of, for example, schizoid personality, and now he is very talkative, no, he is very already that histrionic personality, so there must be something wrong. So do not take that for granted. Sometimes in our places, in our community, we already some judgment of, oh, she's only like that. But we do not know that it's already a disease, a psychiatric problem. That is premorbid personality. So, as I've said here, the indication, so that the indication of neuropsychological assessment, so that we will know whether it is an exacerbation or remission. No? So whether the disease, no, is an exacerbation of his depression, or it is a remission, no? And it comes back again. No? Because sometimes diseases like the schizophrenia, the earlier to that is only 1 year. I forgot. Schizophreniform disorder. Sometimes schizophreniform disorder, the psychiatrist will already conclude that, oh, this is only schizophreniform disorder, or said this is only a 3-year treatment, but only to find out that later that is schizophreniform disorder becomes schizophrenia, and that is already, there is already exacerbations of symptoms, and you have to change already your diagnosis. Because the first time that you saw the patient or you see the patient, you cannot immediately say, unless you are already experienced, you have some long time consultation of some different psychiatric illnesses. But as I've said, in neuropsychological test, or even just a clinical eye, you will know that this is not anymore the disease that you have diagnosed before. So this is an exacerbation and you change already your diagnosis. In psychiatry, it is not definite, no? That when you see the first time the patient, for example, substance abuser, the patient comes to you who is a substance abuser, for example, has been using shabu, and now he comes to you, he is psychotic. No? You cannot say the first time the patient comes to you that definite diagnosis, he is a substance user. Diagnosis, that's your diagnosis. Substance use disorder. Because later that patient becomes schizophrenic. So it's very important, that's why you have to educate your patient so that even if you do not even have your neuropsychological evaluation test, you just ask your patient, you just see the signs and symptoms, the exacerbations, you will know that this patient is not only a substance abuse disorder, but you will know that this is already, the patient is becoming into a schizophrenic patient already. That is exacerbations. And remission, sometimes depression, there are depressions that are treatable, especially if it depends on the kind of the person. It depends on the support of the family. It depends on the vulnerability. It depends on the degree of the illness. It depends on the chronicity of the illness. So, example, if you have just a depression and there is no, maybe I will lecture to you later the precipitating factors and the precipitating, and the other one is the, when you cannot change that anymore, the age, the race, no? You will know that the patient will have remissions or not, no? Even without psychological evaluation. But it just being shown here that neuropsychological evaluation or assessment is also a part of your diagnosis. And you will also know that this disease can be remitted or not. No? Or there will be an exacerbations later. It is only shown here that neuropsychological evaluation or examination can detect also whether the patient has exacerbation or remissions. No? So you will also know that the patient is deteriorating in the patient's baseline functioning, meaning to say here, further deterioration in the patient's baseline functioning follows each relapse. Meaning to say, when the patient has several relapses, when the patient has exacerbations, remissions, exacerbation, the more that the patient has a poor prognosis, because the patient, every time that the patient relapses, there are already brain cells that are being destroyed. So as much as possible, we educate the patient to have continuous medication to prevent relapses. Because every time that the patient relapses, there are always cells in the brain that are being destroyed. So the more that you relapse, the more that you will or the patient will deteriorate. So parang nawawalan ng pag-asa if you have so many relapses. So it would be better that if the patient had a first signs and symptoms, you have to bring the patient immediately to a doctor to avoid relapses. And medication is not meant to be taken in order that you will be addicted. No. Medications here is very important to prevent relapses in order that deterioration will not go into the patient's life, no? So it's sometimes because patient will say, Doktora, inom na lang ako, inom ng ng gamot, baka ako ma-addicted nito. Medications here in psychiatry are meant to be taken for a long time, for a lifetime, to avoid relapse or to avoid further deterioration. So the doctor will tell you, do not stop the medication unless you are being told to stop. Because some patient would tell, so many patients that I have, they would say, Doktora, maganda naman siya, hindi naman siya bumabalik yung sakit, okay naman siya. No? You just observe, no? First time that the patient has psychiatric problem, usually the treatment is 1 to 3 years. Even 3 years, no? 1 to 3 years. It depends on the support, of course, the support of the family, the vulnerability of the patient, the age of the patient during the time that he manifested psychiatric problem, because when the patient had his or her psychiatric problem when he is very young, the patient has a very, very poor prognosis. Why? Because this kind of illness will not afflict the very young yet. Because young patient, of course, do not have complicated things yet. But also it depends on the kind of the family, the kind of the support of the patient that is given to her, to the family, to the friends, to the community. Before, psychiatric problem is a stigma. But now, I appreciate there are patients who would just come to me. They are crying because they break up with their boyfriend. I appreciate that. No? Rather than you come to me when you are already depressed, very depressed, and you have been very depression for a very long time already, for 1 year already. But now there are patients, even employee, they would come, they would talk to the psychiatrist because they had a conflict with their employer. So I appreciate that, because before they believe that when a patient comes to a psychiatrist, they thought that the patient is having is psychotic. No, it's not. Even in the United States, they already bringing the patient, even if the patient has this one symptom or signs of some behavioral problem, no? Unlike here, but we start educating that when the patient had a first diagnosis or the first behavioral or psychological symptom, bring the patient immediately to psychiatrist. Because some of them would say, they will let the psychiatrist will let the patient take that for a long time. No, we do not make the patient an addict for the medicine. What is an addiction? An addiction is when you do not need that medicine. That is an addiction. But as long as you need the medication, that is not an addiction. Like, for example, using shabu. That is an addiction because you did not take a shabu for a long time. But when you take the medicine for a long time, because of the prevention of relapses, that is not an addiction. Many patients are like that. But however, I am already, I appreciate already because the patient already realized that the caretaker already realized that if they will stop the medicine, because many times I educate the patient, the caregiver, that if you stop the medicine, there is a possibility, always a possibility that the patient will go back. So we go back to the very beginning. So most of my patient has a good what this good compliance with the medication, because I always educate the patient. So they can't, even if they know that they're already well, but when I explain to them, especially the subchronic psychiatric problem, they would come to see for consultation, because that would entail further deterioration again if there are several relapses, because you stop the medication because you think that the first time that the patient is already very well, they thought that, oh, it's good, we will not take the medicine already. And here comes again, after 3 months or 4 months, Doktora, nagbalik naman liwat. I told them, di ba, I told you to come back monthly. So you have to educate your patient. You ask your doctor. There are doctors, of course, I am not generalizing. No. There are doctors who do not explain their patient. But if you know that you cannot understand why you are taking the medication, what is the medicine for, why I'm taking this, and why I'm taking for this period of time, you have to ask your doctor. Even if you are a doctor, you have to ask. So that's why, even if you are the first honor, the valedictorian, the cum laude in your class, if you do not know how to handle patient, you will have no patient, mind you. But if you will let the patient realize and explain why they are taking the medicine, the patient will be coming back to you. Every now and then, you will tell, you know, the patient, if they created trust already, if they created rapport already, they even ask you, Doktor, ano tagbobotosan? No? Many things. Doktor, ano takpapalito ni takwarta? No? So they are like that. No? So be sure that you have to explain, no, why the patient is taking this kind of medication, the dosage, the duration. You have to explain to them. Although it can be assessed, so you need not assist that in your neuropsychological evaluation, because as you go along with your practice, you know already when to stop, and you know already that this will come again. No? But sometimes the caregiver are the one who are to be, what you call, blamed, because the patient are willing to come for consultation again and again. No? Positive symptoms tend to become less severe with time, but the socially debilitating negative. You know, positive symptoms. What are the positive symptoms? Hallucination, delusions, what else? The negative symptoms are usually, for example, they do not want to go out, they are very, very lazy. For example, the schizophrenic patient, they have so many, their hallucinations are very, what you call that, word, no? For example, ay, Doktora, I can hear the voice of the President of United States, no? So that is one of the negative symptoms. So the socially debilitating negative or deficit symptom may go in severity or may increase in severity. So you can see that if the patient has more negative symptoms, please see na in the book what are the negative other negative symptoms. No? Alogia, or you do not have interest in the world, your hallucination is usually somatic. For example, I do not have a heart, I do not have an intestine. That is the negative symptoms already. So please see that in the book. If you have a negative symptoms, usually the patient is debilitating and it is very difficult. It go into severity. You cannot say that the patient can stop. They have to take that for a long time. But most of the psychiatric patient, I encourage them to take the medicine, because we usually taper, to take the medicine and not to stop until I told the patient to do so. But most of the patient would come because I usually taper medication. When they are already functioning, I usually taper the medication. Of course, if you taper the medication, there is less, what you call that, the price, no? You can already save. But if the patient will stop, then continue, then stop, the more that the patient will become severe, the more that they deteriorate, the more that they will spend a lot of money. That's the rationale behind of stopping the medicine. Course and prognosis. So what are the good prognosis example? As I've said before, when the patient has symptoms of psychiatric problem, when they're still young, the prognosis is very poor. So the least that the patient we can stop the medicine. Usually, good prognosis would entail a late onset. And there is identified precipitating factors. The other one is predisposing factors. You know, predisposing factors, example of predisposing factors are your age, your race, what else? Your gender, no? Precipitating factors are external factors that can be controlled. That is precipitating. Predisposing factors are those factors that cannot be controlled or cannot be changed. Precipitating can still be controlled, can still be changed. For example, drinking liquor, that is a precipitating factor. Of course, age, you cannot change your age anymore. That is a predisposing factor. You know? So I'm just explaining to you when can we say that the patient has a good prognosis? No? Acute onset. No? Because gradual onset, dahan-dahan usually has poor prognosis, but it depends on, as I've said, on the patient vulnerability, the patient support of the family, the patient personality. There are many factors, although it's not definite that, of course, when I say late onset, she has a good prognosis, no. There are many other factors that can, of course, one is the precipitating factors and the predisposing factors, of course. So good premorbid social, sexual, and work history. So, of course, if the patient has a good premorbid social characteristic, for example, the patient is sociable when he was growing up, no, he's not having a schizoid personality, no? So there's likely that the patient has a good prognosis. These are just an example. These are just possibilities, no. I'm not saying that this is. I can say that this is it, that you have a good prognosis. These are just possibilities that if you have this characteristic, you will have a good prognosis. No? So memory. Another example of neuropsychological assessment is memory. No? So short-term and recent memory. So recent memory, for example, what did you eat this morning? No, short-term memory, your immediate memory. For example, you let the patient, you want to count, let the patient count again. No? Often first sign of cerebral disease and of aging. So meaning to say, so that's why you said that, oh, you're already old because you cannot, you are forgetful. No? So often first sign of cerebral disease, but it does not always say that if you are having an aging, you are having a memory problem, you are already aging. It is not definite because there are other cerebral diseases. No? There are other factors or organic diseases that would affect memory. Like, for example, stroke. Like, for example, brain tumors. So those are the things that would affect memory. It's not only aging. aging, it depends. No, there are many studies already that if you just practice reading, you cannot have that kind of unforgetfulness or forgetfulness that is expected of an aging patient. No? So practice reading, no? And you have to go out, you have to have exercise, no? Because you can see that memory is not only a function of aging, it is also a function of other cerebral diseases. No? So I already said immediate. There are 4 kinds of memory, of course. Your immediate, I've said, I told you, you count, no, or name a place at that instant and let the patient follow what you said. No? Red, blue, and yellow, you let the patient say again. So that's an immediate. Recent, what is the patient, what did the patient eat this morning? No? Recent past, last month, no? What did you do last month? What happened? Remote, of course, your vivid childhood memory. What happened? Which you cannot forget during childhood. So there are 4 aspects of your memory: immediate, present, present past, and your remote. So you have neuropsychological evaluation of your memory. That is Whistler memory scale. No? So it is most widely used memory test battery for adult. No? So visual memory for the science. No? So you can see retention of a paragraph, verbal paired. No? So meaning to say sometimes you have to talk and there is something being shown to you. So if you can still recall, no? Verbal paired, no? For example, you talk and then you say it again. No? That is immediate. So that's a part of your memory, no? Or the psychiatrist or the psychologist would show something and then you said it and then you tell again what you have read or said or what had been shown to you. Then paragraph retention. You are told to read a paragraph or a sentence, then you are asked what did you read or what has been your comprehension. No? What about the readings that has been shown to you that you read? No? Recall of alphabet. No? So it's just also another kind of immediate memory. Orientation, di ba? Oriented to time, place, and person. Oriented, the first thing that would be that get lost is time. No? Time, then place, then person. And the first time that would come back is the person, place, and the last that would be recalled is the time. Again and again, that's why do not be distorted when somebody would say, the family would say, Doktora, kilala pa naman na ako na they still know the time, the place, the person, they still know me, no? As I've said there, we have different aspects of our brain that is particular role on orientation, on somatosensory. You know that already, no? The parts of your brain, the lobes, the different lobes of your brain that is responsible for the different aspects of our behavior. The motor aspect, you know already. The comprehension aspect, you know. Listening, no? Talking, you know what part? The temporal lobe, you know that already. No? So those are the things that you're counting backward. That's also immediate, no? Memory quotient. No? We least like to use that. As long as you know, you can give the person the immediate, recent, past, and remote memory. So you have Benton Visual Retention Test. So yeah, Benton Visual Retention Test is, there are cards, no, on this. There are different shapes, and you are told to draw or to follow that test. If there is a distortion of the drawings that you will do, there is something wrong organically in your brain. That is usually done in mental retardation, in tumor, in stroke. That has been Benton Visual Retention Test. I already told you, orientation for person or place, no? Brain damage. So when you have a brain damage, there are problems more on the recent memory. Recent, remote. So when there is a problem or organic problem, they are more likely to forget the recent memory. Perceptual and this is the one that I told you that it's almost the same, that you are being shown with a series of different shapes. Perceptual and perceptive motor performance. This will also tell whether you have an organic brain problem. For example, you are being told to draw a circle and you will draw like a square. So there must be something wrong. Sometimes the patient would say, or the client would tell, Doktora, di naman kumaping na drawing. Or sometimes we will let them draw a person. Doktora, di naman maupik na drawing. We are not after that. We are after the result of your drawing, not the beauty of your drawing. So for signs of organic dysfunction. So as I've said, if there is problem of the shapes that you draw, it would tell that there is something wrong with an organic problem in the brain. Complex visual discrimination. So we rarely use this test because it can be already incorporated in other tests. Language. So of course it is very, it can be already detected when you ask the patient, stuttering, minor defects in the use of language. So there's a brain damage. Stuttering, for example, the way the person talks, a phasic patient cannot talk. And there are many fail to give the words they can think of. Sometimes the patient, they would say that, Doktora, it's in my mind. Especially stroke patients. They can write what they think, but they cannot put that into words. They cannot talk what they are thinking. So they rather write. This usually happens when there is a brain damage, like the stroke, as I said. Fail to give the words they can think of, beginning with a given letter of the alphabet. But usually the whole word, they cannot anymore tell. Sometimes they would just say, it's in my mind. They would try to show that it is in her mind, his mind, her mind, but they cannot say it. So, but when they write, you will know that it's in their mind really, because it is written. Attention concentration. EEG abnormal, but not all of EEG. Sometimes, as I've said, so as we say, it is not, it's a minor role only. It doesn't be, EEG would reflect when there are, what you call the seizure problem. Right? The EEG is abnormal when there are seizure problem. However, there are seizure that the EEG is normal. So not anymore you cannot rely that when there is a seizure, or if the patient has a seizure, the EEG would always be abnormal. No. There are many patients that EEG is normal even if they are on seizure. So as I said, it is a minor. These examination are just minor. No? What's important in psychiatry and even in any other diseases, 90% is your history. If you have a very, very good history, you can diagnose even in other medical diseases. Likewise, in psychiatry, you will know that if you have a very good history, you can already assess the patient and you can also diagnose. In Manila, before when we were still students, no, they would say, they would immediately have a laboratory examination. But here in the province, we rely more on clinical eye. Especially if we have so many patients and you are always subjected to that particular diseases. Because of you have been already exposed to the many diseases, the same diseases. The first time that you see the patient, you can immediately diagnose that this patient have this kind of illness. Because here we do not rely more on laboratory, although now it's already, we have a high technology, so there are already laboratory examinations that we usually subject the patient. But before, we rely more on clinical eye and history. But until now, I hope every one of you will still believe that history is still very important than laboratory. Maybe laboratory is a confirmatory, but if you have a very, very good history, as I've said again and again, you can already diagnose or assess the patient's illness. So behavioral index, brain damage in children may take in many forms. So we already discussed about the examination that we have to take in children, even just in drawing. Children, by the way, cannot, of course, children does not, if they do not go to school yet, they cannot write. So you cannot examine the children just like the adult that they have to answer the exact sentence completion test. In children, they use in the form of toys. For example, they use dolls, they use the modeling clay, they use other form of playing characteristic that would tell that they have been abused, they have problems, psychological problems, because they are not like adults that they can already express. So their form of expression is in the form of playing. So the psychologists would usually play with the children. While playing, you keep on asking, because they have a different mode of the use of the words. Unlike in adult, that we are already definite with the words that we use, especially in abused children, especially in children, in special children. Children, because they do not yet write and they do not have the exact word. That's why when children are already grown up, that is the time that they're able to reminisce, or they can remember what had happened when they were still a child. So this is the time that it would come out that they have been abused, the way they were brought up. That is the time that they relate Why? Because when they are children, they still lack words that can be expressed, or wherein they can recall, because they still lack vocabulary. 6-year-old child, maybe they have 15,000 words already. But younger children, of course, they still lack words. So even if it's already in their brain, it is just embedded, in their unconscious, because they do not have yet enough words that wherein they can identify or they can express. So when they already grow adult, or as they go to school, that is the time that they can remember of what had happened to them. But children, you play with them. The psychologists will play with them again and again. I told you, as they play with the dolls, you will be asking, and you can already see the sign, the behavior of the children while playing with them, because it is being shown in their toys. Because in psychiatry, we usually give the children a toy that they can express through the toy or through the toys, like the modeling clay, like dolls. So you have other tests, general intelligence test. So you have Stanford-Binet test, Whistler preschool. This is in children, Whistler preschool examination. Perceptual and perceptomotor performance. Adequate verbal skill but defective visual perceptive and visual performance. Copying of design, even in children, if they're already going to school, they can copy the design or model, drawing, or in Bender Gestalt test, as I've said before, it is already reflected if they have organic problem. Language, gross maldevelopment of oral language abilities. So you can already identify when children, they're still a child, they're growing, you can already identify if they have language problem ability. Motor performance, inability to carry out movements, sequences on command or by imitation. So if the children cannot carry out of what you are telling them to do, the actions, there is something wrong with their brain. You command them to sit down, like the, what you call that? Forgot the disease, They cannot sit down. They're very hyperactive, So there is something, so you can have that so-called brain problem, Organic brain problem. That is motor performance. Then you can have comprehensive testing. So this one is, you can test the wholeness of the behavior, through the comprehensive testing, the psychological function of the person, cognitive function, motor function, memory. You know already what are the tests that are being used in your memory. I told you the immediate, the recent past, the remote. I told you already what are the memory that could be, that you should ask, that can be asked. So the tactile, the auditory. So of course you have your auditory test in children, especially visual, receptive, and expressive speech. Anyway, you just have to talk to the children. And comprehensive testing is used when the child is already 15 years of age. And these are the following that you have to ask the child. So a specific type of problem, dyslexia, cannot understand. They cannot understand what they are reading, Comprehensive. Halstead Rayton battery of neuropsychological test, effect of specific brain lesions. So most of this testing this one is not being used here, But I just want to show it that this is also a neuropsychological test used for organic brain disorder. So laboratory tests, like in any other diseases, we have also laboratory tests in psychiatry, But as I have said, it is not a confirmatory examination, unlike in other diseases. Like for example, leukemia. So when you test the patient in a laboratory, you will know that the test is not even, Not all leukemia have, what you call that, disturbance of the result of the blood test. So these are just example of the laboratory tests that may be given to the psychiatric patient. Of course, the basic, the CBC, your hematocrit, hemoglobin, renal, liver, and thyroid function. Then your thyroid function, that is H, E4 test, dexamethasone test. Although it is used here in mood disorder, but rarely that we use the dexamethasone test because, as I've said, just by talking to the patient, just by taking history of the patient, just by having a regular consultation of the patient, you will already know that this patient will have a depression or a bipolar 1 disorder or a mood disorder. It is just want to show that if ever you will encounter this test, you will know already that this test is being used for a bipolar 1 disorder or a depression test or a depressive disorder or a mood disorder, dexamethasone test. Then you have catecholamine, So PTSD, severe depression. So, but however, again and again, we rarely use this test as a laboratory because, as I've said, you can already take this one during your psychological evaluation, during your history, even PTSD, post-traumatic stress disorder. Even if you will not test the urinary norepinephrine, you can already detect that this is a PTSD or severe depression, even if you do not have this catecholamine test. Antipsychotics. So there are antipsychotics that can cause problem of blood examination. For example, clozapine. So clozapine can cause agranulocytosis. What is agranulocytosis? Reduced number of your red blood, your RBC or your hemoglobin. So when some psychiatrists are not comfortable to use clozapine. But I have tested some patient, although if you're already experienced, you will know the maximum dosage that you will give your patients. Because I tested the patient for this granulocytosis. So clozapine, when I gave when I give 100 milligrams, it goes back to normal. Their CBC would go back to normal. So it depends on the doctor whether they are comfortable using the antipsychotics because it could affect the CBC. No? So you have to, it would just show that this antipsychotic would cause a granulocytosis. So it is for you if you will become a psychiatrist, if you are, even if you are not a psychiatrist, if you will be giving GP, you will be giving clozapine, it is for you if you will subject the patient for laboratory examination because it would cause a granulocytosis, the clozapine. Then you have your monoamine oxidase inhibitor. We seldom use it here now. So it can cause orthostatic hypotension. No? When the patient is on lying down, no? And you take the BP, so the BP is very low. So anyway, we seldom use this one. But this one, clozapine, we're still using that until now. And even me, I'm still using that clozapine. So again, you have another lithium. Your lithium is used for your, this is an anti-manic drug. Although there are many anti-manic drugs already, like the Depakote, the valproic acid, but previously lithium was the sole anti-manic drug. But however, the side effect is, you know, it has a renal problem. It can cause hypothyroidism. It can cause leukocytosis, no? And it can cause lithium delirium. No? So you can also subject the patient for laboratory examination for lithium content in the blood. But if you are already comfortable and you have been there for a long time, you're experiencing patient taking lithium and the patient is stable, you may not have a laboratory examination. But if you are new and you are not comfortable, you have to let the patient subject for a laboratory examination and see to it that the patient is clinically, no? Of course, you have to take the patient problem BUA, no? For blood urea nitrogen, no? What else? Problem for laboratory for other renal examination. Hypothyroidism, your thyroid hormone. No? Leukocytosis, your blood. No? For you to be comfortable when the patient is taking lithium, in case you cannot give other anti-manic drugs, because there are many anti-manic drugs now, like carbamazepine. Carbamazepine is an anti-manic, but it is used also as anti-seizure. Diba? Carbamazepine is an anti-seizure and it is at the same time an anti-manic drug. Or when the patient is violent, you can give carbamazepine. There are intelligent patients wherein they will ask, Tutora, paano man ini? Para seizure man ini, wari ko man seizure. Diba? So you have to explain that carbamazepine is used as a drug or as a medicine, not as an anti-seizure in psychiatry. Why do we use carbamazepine as an anti-manic or in violent patient, but at the same time used as an anti-seizure drug? We use carbamazepine on the precept that carbamazepine, and when patient is violent or anti-manic, there is the firing of the brain brain cells are the same during seizure and during violence and during manic. That's why carbamazepine came out as a drug for anti-manic, because of that percept that there is the neuronal stimulation that is all together. Likewise in seizure. But however, the problem of carbamazepine is the Stevens-Johnson syndrome. Have you seen the Stevens-Johnson syndrome? The Stevens-Johnson syndrome, as if it affects the skin. The skin is almost peeling all the way. No, that's carbamazepine. But if you will stop that, the peeling of the skin will stop. That is the danger of using carbamazepine. But again, if you are comfortable and you have been giving your, I am using carbamazepine, no? 200 milligrams, no? If you're comfortable and you have been using carbamazepine for a long time and you see that the patient is stable, you may continue. But if you are not comfortable, you may have an examination, laboratory examination, like it is said there, CBC, your platelet count, reticulocyte count, no? So that's very important. But the danger for carbamazepine again is Stevens-Johnson syndrome. So valproate. So valproate, that is used as an anti-manic drug also. This is in lieu of your lithium, because your lithium has a very dangerous effect like your carbamazepine. All the valproate or valproic acid causes thrombocytopenia, but it is very nil. No? So we rather use valproic acid or the valproics like the Depakote, no? Or the Pamax. We rather use valproic acid rather than the lithium or rather than the carbamazepine. I am even given 500 milligrams. The highest is 500 milligrams 3 times a day. And you can see that patient's stable. No? So again, it depends on your comfortable. If you're comfortable in giving the patient, but for a new, and if you are not comfortable, if you are working away from the city, it would be better that you give valproic acid in as an anti-manic drug. Or if the patient is very violent, you can give valproate or valproic acid or Depakote or the valproic acid. So other is your lumbar puncture. That's very seldom. No? We already do that when there is an infection, no? Seizure with infection. No? We do lumbar puncture. No? Urine testing, substance abuse. Of course, there are specific reagents that being used when you are using urine testing in what you call that, amphetamine. Use of amphetamine, so it can be seen in urine. But however, there are reagents. But if you are already in far-flung areas, as I've said, history is the best. Okay, so I think that would end our lecture for this afternoon. If you have any question, we can entertain. I can entertain if you have any question, but if there's none, maybe you would like the soft copy.
Yes po, Doc.
Okay. Yeah, nalayan pagkatalit soft copy. So, no question? Okay lang? Ready for the exam? When is your next exam? When is your next Tuesday? I will just combine your second quiz with your bi-monthly also. Okay?
Okay po, Doc.
Okay. So, sige, yan na lang. Yan. Ano, yan.